This is N&I Bites Big Learnings, a podcast where fellow healthcare professionals converse about the latest on nutrition science. Join us as Renan Shamir and Agnes Leung share their knowledge and insights on harmonizing perspectives from the East and West in the prevention of food allergy.
Welcome to our podcast, N&I Bites Big Learnings. My name is Renan Shamir, and it's my great pleasure to welcome Professor Leung from the Chinese University of Hong Kong to today's podcast. Professor Leung is a pediatric immunology, allergy, and infectious disease specialist at the Chinese University of Hong Kong. She received her medical degree from the Chinese University of Hong Kong and completed her pediatric residency and fellowship training, including a visiting fellowship at the Murdoch Children's Research Institute in Australia. Professor Leung research focuses on developing effective preventive methods and novel treatment strategies to food allergies, leading several important clinical trials on innovative immunotherapy approaches. Her work aims to identify reliable biomarkers for personalized food allergy treatments while delving into the clinical and molecular characteristics of allergies. Professor Leung's leadership has positioned Hong Kong as a regional hub for allergy research. She leads the Asia-Pacific Research Network for Anaphylaxis, uniting allergy centers across Asia to collaborate on research into anaphylaxis and preventive strategies. Additionally, she holds significant positions such as board member of the Asia-Pacific Academy of Pediatric Allergy, Respiratory, and Immunology, and an active committee member of the Anaphylaxis and Allergy Prevention Committees of the World Allergy Organization. Thus, it is an honor for us to have Professor Leung, a world leader in her field, with us today. Professor Leung, today we are discussing your paper on prevention of food allergy, Harmonizing Perspectives from the East and West, which appears in our latest issue of Annales Nestlé. Would you like to say a few words to our audience before we begin?
Thank you so much for having me here today. It's truly an honor to be a part of this podcast and to contribute to this important series. Today, we will be discussing my recent article, which explores how cultural, environmental, and dietary differences influence the development of food allergies. By hoping to bridge insights from Eastern and Western perspectives, we hope to provide practical strategies that can not only help parents, caregivers, but also healthcare professionals to reduce the risk of food allergies and improve children's health outcomes. So I'm excited to share the content of the article with you all.
Great. Now, your paper is part of a series on complementary feeding and future health, and our hope is that many of our listeners will enjoy our podcast and your paper and be able to use the information to improve children's health. Now, in the introduction to your article, you discuss the increasing prevalence of food allergy, and we will get back to it. But before we do, can you explain to us what characterizes it and how it is different from intolerance?
Thank you, Professor Shamir, for the question. Food allergies and food intolerances are often confused, but they are fundamentally different in their mechanisms and manifestations. Food allergies involve an immune system response, and often food allergies cause systemic reactions. In contrast, food intolerances do not involve the immune system at all. Instead, they occur when the body has difficulty digesting or processing certain foods, often due to enzyme deficiencies or sensitivities to food components. For example, lactose intolerance results from a deficiency in the enzyme lactase, which is needed to break down lactose in dairy products. Symptoms of food intolerance are usually limited to the digestive system and may include bloating, gas, diarrhea, or stomach cramps. Unlike food allergies, food intolerances are not life-threatening, though they can cause some discomfort.
Thank you. And some words on IgE-mediated versus non-IgE-mediated food allergy?
So food allergies can be further classified into the two main types, as Professor Shamir mentioned: the IgE-mediated so-called immediate type of food allergies, or the non-IgE-mediated so-called the delayed type of food allergies. For the immediate type of food allergies, the immune system produces immunoglobulin E, or we call that IgE antibodies, in response to specific foods. Upon re-exposure, these IgE antibodies trigger the release of chemical substances like histamines and other inflammatory mediators from mast cells and basophils, leading to rapid and sometimes severe symptoms. On the other hand, the delayed type of food allergies often are driven by immune mechanisms involving T cells or other inflammatory pathways. The exact mechanisms behind non-IgE mediated food allergies are still not fully understood, but they are distinct from the immediate type of reactions in terms of timing and presentation.
Great. So I wanted to ask you about symptoms, but you already elaborated on this. So my next question would be, is there a universal threshold or there are individual thresholds for developing the reaction?
This is a very important question, and I think it touches on a key challenge in managing food allergies. The concept of threshold, I would say it refers to the minimum amount of an allergen required to trigger a reaction in someone with a food allergy. Research has shown that thresholds vary significantly between individuals. For example, someone with a peanut allergy might react to just traces amount of peanuts, while another person might tolerate a small quantity without any symptoms. So this variability makes it difficult to establish a universal threshold that is safe for everyone.
So we cannot determine a level that no one will respond to, right?
Yeah, that said, scientists and some regulatory agencies have worked to determine reference doses and levels of allergen exposure that are unlikely to cause reaction in the majority of allergic individuals. These reference doses are used to guide food labeling and manufacturing practices. You may have seen some packaged food which have some may contain warnings. However, it is still important to note that these levels are based on population studies and statistical models, and they still cannot guarantee safety for every individual.
Thanks. Now, your paper discussed the differences in prevalence between West and East. Let's start with what has happened and happening in what you describe in your paper as westernized English-speaking countries.
Thank you, Professor Shamir. So let's dive into the main topic of today about the food allergy prevalence and how it affects us. So we started to understand that food allergies are becoming more common in Western English-speaking countries, for example, in the United States, United Kingdom, and Australia, right around the middle of 1990s. In United Kingdom, for example, peanut allergies in young kids aged 3 to 4 years old jumped from 1.3% in 1993 to 3% in 1998. But since in the early 2000s, the numbers have mostly leveled off. In Australia, a study in Melbourne also found that about 10% of 1-year-old had food allergies between 2007 and 2011, with peanut allergies affecting around 3% of these children. When the researchers checked again, repeated studies in 2018 to 2019, the peanut allergy rate had slightly dropped to 2.6%, overall suggesting that the increase in food allergies may have hit a plateau. Similarly, in the US survey, showing that food allergy rates stayed pretty steady around 7 to 8% between 2009 and 2016.
Professor Leung, we discussed prevalence, but I think it is important for our audience to remember that we are mainly discussing IgE-mediated food allergy. Is there good data on the prevalence of non-IgE food allergy?
For non-IgE food allergies, for example, food protein-induced enterocolitis syndrome, these conditions haven't been studied as much as IgE-mediated allergies, and most of the data have come from smaller regional studies rather than big national wide surveys. But there are reports showing that FPIs are becoming more common in places like the United Kingdom, the United States, parts of Europe, Israel, and Japan. In particular, there are reports showing that egg-induced FPIs is coming on a rise in Japan, while peanut-induced FPI seems to be reported more frequently in the States. We still need more research and more studies in this area.
Thank you, Professor Leung. Now, coming back to IgE, what about anaphylaxis rates in the West?
That's very important. Even though I've mentioned that food allergy rates have leveled off in Western countries, severe reactions like anaphylaxis are still on the rise. In the United States, emergency room visits for food-related anaphylaxis in kids shot up by 200% between 2005 and 2014, with the highest rate seen in babies and toddlers. Australia saw a similar trend with hospital admissions for anaphylaxis increasing 1.5 times between 2005 and 2011, especially in kids under 4 years of age. So overall, I think while food allergies are necessarily becoming more common, reactions are still can be very severe. So it could be due to better awareness and diagnosis, changes in food exposure, or other environmental factors. Either way, it highlights how important it is to be prepared. For these patients, we often advise them to carry an epinephrine auto-injectors and having an emergency plan that can make all the difference.
Thank you, Professor Leung. Now, data on food allergy in the East is limited, yet can you elaborate a bit?
In westernized, but non-English speaking countries like Israel, Japan, food allergies are still becoming more common, though the rates are still low compared to places like the States, UK, and Australia, as we've just discussed. For example, in Israel, food allergy rates went up from 0.8 in 2002 to 2.8 in 2018, so there is an increase over time. Japan saw a similar increasing trend, with rates rising from 0.3 in 2010 to 0.8% in 2019. So again, this suggests that countries, as they're adopting a more Western lifestyles, diets, and environmental changes, food allergy may be becoming more common. However, the good news is that the numbers are still much lower than in the English-speaking Western countries.
I understand. Well, that's a very elaborate response. Thank you, Professor Leung. Now, one striking finding is that the prevalence of food allergy varies between studies. Is it the methodology of the studies? Is it genetics? Is it environmental factors?
This is a million-dollar question. The differences in food allergy rates between studies are pretty noticeable. I think there are a few key reasons. First, how the studies are done makes a big difference. Some rely on self-reported symptoms, while some use skin prick tests or oral food challenges. As we know, food challenges are the most accurate method, so studies using them tend to report lower allergy rates compared to those based on self-reports. The other reasons may be somehow related to genetics. This is not as clear, but we know that some people tend to develop eczema more frequently than the other people. Mutations, for example, in filaggrin gene, which is linked to eczema, are more common in certain populations and can increase the risk of food allergies. And most importantly, I would think environment matters a lot. A great example is Asian immigrants in Australia. They have a much higher food allergy rates than their relatives who stayed in Asia. Since their genetics are simply the same, the increase is likely due to environmental factors like urbanization, pollution, diet, or even hygiene and gut microbiome changes. So similar trends have been seen in places like China, where food allergy rates have gone up alongside economic growth in urban city, but not yet in the rural area.
This is very enlightening. I would say $1 million answer to the question. So we discussed prevalence, but it's not only that. The specific allergens are also different. Can you highlight some differences for us and shed light on the reason for the heterogeneity in allergies between populations?
This is a very interesting phenomenon that we have seen, because specific allergens that trigger food allergies indeed vary significantly between regions. Professor Shamir has mentioned, in Western countries, the most common allergens are cow's milk, peanut, tree nut. For example, in the States, peanut and tree nuts are leading causes of food-induced anaphylaxis, particularly in older children and adults. But in Eastern regions, we're seeing that seafood allergies, for example, allergies to shrimp, to crab, are much more prevalent. For example, in the Asia Pacific Research Network for Anaphylaxis, we found that shellfish is the most common trigger of anaphylaxis in many parts of Asia, particularly as children grow older. Additionally, through that registry, we saw that there are region-specific allergens like wheat in Japan, buckwheat in Korea, mango in Taiwan, in China, and bird's nest in Singapore. They are noticeable. In contrast, peanut and tree nut allergies, while still common in Westernized Asian cities like Hong Kong and Singapore, are less prevalent in other parts of Asia, like Thailand, or in the mainland of China, like Qingdao. This is our main finding from the anaphylaxis registry. In other parts of the world, for example, in Latin America, we also found some differences. For example, milk and eggs are most common triggers for anaphylaxis. We also see triggers like shellfish and fresh fruits. But again, peanuts account for only a small percentage of cases with food allergy. So we would think that dietary patterns are largely driven by regional allergen exposure. So this is very important when we think about tailoring prevention and management strategies as well for the different regional contexts.
I'm living in a country where most children are exposed to peanuts protein in the first year of life, and the lower prevalence of peanut allergy in our country compared to similar populations who avoided peanuts was the trigger for the LEAP study. Can you shortly remind our audience of the methodology and findings of the LEAP study?
The LEAP study was a landmark randomized controlled trial designed to investigate whether early introduction of peanuts could prevent peanut allergy in high-risk infants. So for this study, they enrolled 640 infants aged around 4 to 11 months who were considered high risk due to severe eczema, egg allergy, or both. And they were randomized into two groups. So one is a consumption group who consume peanut-containing foods at least 3 times per week, or the avoidance group who avoided peanut-containing foods entirely. The study followed up these children until they were 5 years old, and the results were striking. In the consumption group, only 1.9% of the children developed peanut allergy by age 5, but in the avoidance group, up to 13.7% developed peanut allergy. This represented an 86% reduction in peanut allergy prevalence among children who were exposed to peanuts early. So the LEAP study overall provided strong evidence that early introduction of peanuts can prevent peanut allergy in high-risk infants.
Thank you. And that study was followed by the EAT study, examining early exposure to multiple allergens. What did we learn in the EAT study?
The EAT study built on the findings of the LEAP by investigating whether early introduction of now 6 common allergenic foods, including peanut, egg, cow's milk, sesame, fish, and wheat, would prevent food allergies in the general population and not just the high-risk infants. So the researchers split around 1,300 UK babies into 2 groups. One, again, started early, eating 6 potentially allergenic foods at 3 months while continuing to breastfeed, while the other group followed the usual recommendation of exclusive breastfeeding until around 6 months. When they analyzed everyone in the study, they didn't find a significant difference in allergy rates, but here's what it gets interesting. When they look only at families who consistently followed the feeding instructions, they find an early introduction reduced food allergy risk by 67%. And the results were particularly impressive for high-risk babies who already show signs of allergic sensitization. For these children, early introduction cut food allergy rates in half, especially for egg and peanut allergies. No babies in the early introduction group develop peanut allergies compared to 2.5% in the standard group. So overall, I think the EAT study changed how we think about preventing food allergy, suggesting that early introduction of allergenic foods, particularly in high-risk babies, can reduce allergy rates without compromising safety or breastfeeding.
That's very important. Now, regarding cow's milk, there are so many conflicting results, as on one hand, there is increased cow's milk allergy in formula-fed infants, but the timing of introduction and the continuity is important. Can you summarize for us what is the current knowledge and when and how should we introduce cow's milk?
I think this is an emerging and very important space that we have to follow up on. Recent research has given us some very helpful insights about introducing cow's milk to babies and how it affects the chance of developing an allergy to it. As Professor Shamir mentioned, timing seems really important. So studies show that giving babies cow's milk protein very early within their first 40 days of life can dramatically reduce their risk of developing an allergy. In one study, babies who got cow's milk this early had an allergy rate of just 0.05%, while those started between 3 to 6 months had a rate of around 1.7%. So that's a huge difference. And it's not just about introducing it early, though. Consistency matters. Babies who get a little bit of cow's milk formula every day from birth seem to be protected against developing allergies. In a large study with almost 2,000 newborns, those who had daily cow's milk formula from birth didn't develop an IgE-mediated cow's milk allergies at all. On the flip side, babies who only had cow's milk occasionally actually seem to have a high risk of developing an allergies. And there's an interesting relationship with breastfeeding too. While breastfeeding provides unparalleled benefits, recent studies have suggested that exclusively breastfeeding babies without any prior exposure to cow's milk protein may be associated with a higher risk of cow's milk protein allergy. But it's important to remember that this does not apply to all infants. For infants already exposed to cow's milk protein in the first weeks of life, ongoing, regular consumption of very small amounts is recommended, but without replacing breastfeeding to promote tolerance. This is important, particularly regarding high-risk infants. In fact, one study found that high-risk infants who received cow's milk proteins in the first few days, but later stopped, had increased sensitization rate.
Well, thank you for this very up-to-date information that obviously causes a lot of controversy, but seems to be the way to go. Now, in your paper, you discuss primary prevention of food allergy, that we can have all podcasts discussing it. In addition to so much material that we find in your excellent paper that we cannot hope to cover it all. Thus, I strongly urge listeners to download a copy from the NNI website, including data on the importance of skincare that we did not mention here. So perhaps we can wrap up by asking you to summarize what are the conclusions of your article.
So in conclusion, I would think that the best time to start giving babies common allergy-causing foods or for healthcare providers to provide recommendations on solid food introduction is really around 6 months old, but don't start solid food introduction before 4 months of age. For cow's milk specifically, the ideal approach combines breastfeeding with targeted minimal cow's milk protein exposure when supplementation is already part of the infant's diet. So this balance supports immune tolerance while preserving breastfeeding benefits. Breastfeeding is great for babies' overall health, while giving them small amounts of potentially allergenic foods helps babies' immune system to learn not to overreact to these foods. What works best might depend on where you live and your family's eating habits. Different regions have different common food allergies, as we have just discussed, and cultural food practices matter as well. So remember that research about food allergies is always evolving. It's still evolving. So healthcare providers should keep up to date with these latest findings to give you the most current advice. What we recommend today might be different from what was recommended just a few years ago. So thank you everyone for listening.
Oh, thank you, Professor Leung, for walking us through this fascinating topic so clearly and helpfully. And to our audience, thank you for listening to this very special edition of our podcast, NNI Bites, Big Learnings. Please subscribe through the NNI 365 app to ensure you don't miss future offerings. Thank you and bye.
And that concludes today's episode. Thank you for joining us with Renan Shamir and Agnes Leung as we talked about harmonizing perspectives from the East and West in the prevention of food allergy. We hope you enjoyed and learned from this quick discussion, fellow experts. Till the next episode.